I'm Dr. Robert Sade, chair of the Cardiothoracic Ethics Forum. The forum puts together a debate every year for the Society of Thoracic Surgeons and picks a topic that is relevant to cardiothoracic surgical practice that is also very controversial. This year, the forum chose the topic of the failing heart of a child who is on ECMO, and the decision has to be made whether to remove ECMO and allow the child to die, or to place the child on a ventricular assist device after removing ECMO and put the child on the transplant list. There's a specific vignette that we've put together to focus the discussion between two debaters. And I'm going to present the vignette and then ask each of the speakers, Jessica Turnbull on my right and Minu Kavarana on my left, to introduce themselves, where they're from, etc. So the case is this. Angela Downing is 8 years old. She has Down syndrome. And when she was born, she had a complete AV canal, which was repaired when she was 5 months old. After that procedure, she was left with moderate atrioventricular valve insufficiency and moderately depressed left ventricular function. She did satisfactorily until she was 4 years old, when she had easy fatigability and nighttime snoring, for which a sleep study was done, and she was found to have obstructive sleep apnea. CPAP was prescribed, but she dislikes the CPAP, and she often removes the mask during the night. Echocardiography, when she was 4 years old, showed pulmonary hypertension, for which she takes sildenafil every day. Angela's AV valve insufficiency is now severe. Her left ventricular function has remained moderately depressed. Her pulmonary vascular resistance is 4 Wood units. Her mitral valve undergoes repair at this time, but because of residual mitral valve insufficiency and poor left ventricular function, there's difficulty weaning her from cardiopulmonary bypass, so she's placed back on bypass, and her mitral valve is replaced. After valve replacement, she still cannot be weaned from bypass because of poor left ventricular function. So she's placed on veno-arterial ECMO by way of chest cannulation, and the chest is left open. Over the next 7 days, Angela fails to wean from ECMO support, and her course is complicated by re-exploration for bleeding and multiple small emboli because of difficulty achieving adequate heparinization. She has emboli to several fingers and toes. Her chest remains open. Her parents want everything done. And the surgical team believes that the possibility of weaning from ECMO is now approaching zero. The only reasonable options seem to be withdrawal from ECMO or placement on a ventricular assist device as a bridge to transplant. The question is, should the patient be placed on the transplant list? Dr. Kavarana believes the patient should be placed on the transplant list. Dr. Turnbull believes the patient should simply be removed from ECMO and placed on palliative care. So I'd like to start the interaction with our two guests and ask Minu, tell us in a nutshell why you think the operation for VAD and transplant is the better option for Angela.
So the reason I think it is the better option is because it's what I would consider the standard of care for an 8-year-old child who is currently on ECMO after an open heart operation. In my mind, there is no distinction based on the fact that the child has trisomy 21 or not. There is a fair amount of data now. In fact, we have 2 presentations that will be discussed today on large multi-center studies looking at patients with Down syndrome in comparison with those that don't have Down syndrome. And we've found consistently that Down syndrome children actually have a better survival, lower morbidity for most biventricular repairs other than single ventricle physiology.
Okay, thank you. And Jesse, tell us in a nutshell why you think that Angela should be removed from ECMO without further support.
I think this is a awful case. And I think we're seeing more and more kids in our cardiac ICUs that have premorbidity upon premorbidity when they come to the spot where they have a cardiac repair that they're unable to separate from bypass and require support with ECMO. I think, unfortunately, in Angela's case, it's not the trisomy 21 that makes me think that she shouldn't be a candidate for heart transplant. It's her course up until this point. The fact that she has a history of noncompliance with her CPAP makes me extremely concerned about her family's ability to facilitate the compliance that will be necessary to sustain a VAD and then a transplanted heart. And I also believe she's already shown us that she has risk for multi-system disease that will make it difficult for her to adequately get through a transplant course. The thromboemboli to her fingers and toes suggests that she's likely had thromboemboli to other important organs, which will be necessary for which will have to work well for her path forward. So unfortunately, because donated pediatric hearts are such a limited resource, I think that Angela's case has made her too complicated to receive that resource.
Okay, and following up on that comment, I'd like to ask, that Angela obviously is in very bad condition at the moment. How can you justify using a scarce replacement heart when so many other children with a much better long-term outlook are on the transplant list? About 20 to 25% of children who are on the transplant list don't receive a heart and die on the transplant list before a heart becomes available. One of them is going to die, one of these otherwise healthy children is going to die if Angela gets one of these rare hearts. How do you justify giving Angela the heart rather than one of those other children?
I'd like to remind everyone that the children that we operate on and place on mechanical support and list for heart transplantation, majority of them are not healthy. They're very, very sick. That's why they're getting a mechanical support device. Many of them are in what we would call INOMAX 1, INOMAX 2, INOMAX 3 categories. They're very sick, multi-organ failure many times, inability to separate from bypass many times, and that's the kind of patient that we take care of majority of the time. And that's the reason why a ventricular assist device is so effective in reversing all that end organ dysfunction and bridging a patient safely to heart transplantation. So Angela preventing another child from receiving a heart transplant is the same as any other child getting listed and getting a heart transplant. It is a limited resource, but we have to be very clear as to who we're going to offer it to and who we're not going to offer it to. And I think that's where this debate really comes in.
Okay. And a question for Jesse. Suppose that Angela has the same history, but has no genetic abnormality. She's a very bright, energetic 8-year-old who's doing very well in school. Would you then put in the VAD and put her on the transplant list? And why or why not would you do that?
Mm-hmm. Yeah, and I absolutely would. I think an 8-year-old, a 9-year-old who does well in school is able to show us that they are able to comply with things necessary to bring about their own greater good. And of course, that comes with the guidance of parents, of course. And I also believe that even if we had an 8-year-old with trisomy 21 who was in school, doing well, energetic, I think that changes the story to the point where she should get a heart transplant too. Sarah Jansen was a disability rights activist in the 1990s who had trisomy 21. and lobbied under the Americans with Disability Act to have a heart-lung transplant when she needed one. She was 35 years old when she got her heart transplant. She had the history, though, that she had been living on her own since she was 20 years old, and she was working as a disability rights activist. And so I think that shows a level of working within external supports where you can have a great amount of success as an individual, regardless of your genetic history. And so for Angela, it is very much my concern that the history of being non-compliant with previous medical interventions, even with the support of her parents, even with the support of the medical team, would make it so that it wouldn't be a fair utilization of the limited resource of a transplanted heart.
Okay. Manu, what do you think about that? That sounds pretty persuasive. I mean, she would do it if it weren't Angela with all of her potential and real non-compliance issues.
I think Jessica's just really made my argument very easy. I think we can't discriminate based on what we think is normal. I think, in my mind, the only reason why I would not offer Angela or any other 8-year-old mechanical support while a child is being supported just 7 days after her open heart operation on ECMO would be catastrophic brain damage, irreversible bowel injury and bowel ischemia, and refractory sepsis, which cannot be controlled. So those are the 3 conditions where I have, and I would definitely recommend not proceeding with aggressive therapy. But other than that, we see miraculous results every day all around the world with kids in Angela's condition. So,
yeah, how do you respond to the non-compliance issue? I mean, non-compliance is something that should keep people off of the transplant list if they're not going to take their medications, et cetera. Now, she's only 8 years old, but she won't put up with her CPAP. She won't keep her mask on because she doesn't like it. Does that weigh at all in your calculus?
I think if that were the case, then we probably wouldn't do any pediatric heart transplantation, because children at that age and younger, or even older, oftentimes are completely dependent on their caregivers. So I think if the caregivers were, we couldn't find responsible caregivers, then I would definitely give it serious thought. Now, in Angela's case, she has a mother and father that have proven to be excellent caregivers. So I believe that she would be no different than any other 8-year-old child.
How do you respond to that?
I feel horrible for what we ask the parents of our pediatric patients to go through. For our medically complex kids, including kids like Angela, we ask our parents to become home nurses, home respiratory therapists, home case managers. We ask them to take on such responsibility in really perpetuating the care that we start with their child. I am sure that Angela's parents are deeply loving and deeply responsible individuals, but they can't keep their 8-year-old CPAP mask on. If any person, 8-year-old or 80 years old, doesn't want to wear their CPAP, the CPAP goes in a closet, it collects dust, it affects that person for their obstructive sleep apnea that's going untreated. If a person with a transplanted heart doesn't comply with medical care, that affects that person, but then that also affects the person who died on the waiting list waiting for a heart. And so her lack of compliance with a relative infinite resource, I think, has serious implications regarding how much risk we're willing to take with giving her such a limited resource.
Okay, I'd like to thank both of the speakers. The oral debate is going to take place at the 2017 meeting of the Society of Thoracic Surgeons. For those of you who don't make it to that debate, the manuscripts from these 2 debates will be from this debate will be published in the Annals of Thoracic Surgery sometime later this year as a permanent record of this discussion. Thank you very much for your attention.